Oh, it's a happy Monday, everybody, and welcome to my show where it really is okay to not be okay. I'm Rae Bonney, a qualified counsellor, workplace mental health specialist, not to mention a very dedicated and an oftentimes enthusiastically disruptive men's issues advocate. It's very rare, but I do dare. With you for the next hour, as always, I'm unwrapping one of the greatest gifts going around, and that is people. Layer by layer, we explore the thoughts, experiences, achievements and challenges of ordinary people, bound to inspire the best you, at the same time acknowledging that it really is okay to not be okay. So turn up your radio. It is the 9th day of April, more than halfway through the school holidays, before our precious, got a bit of caffeine in the system this morning, our precious children head straight into term 2 of the 2018 school year. And they are precious, aren't they, our children? And I personally feel extraordinarily blessed to be the mother of 3 beautifully healthy, upstanding citizens of the world. But for so many reasons, not all parents are as fortunate as I am. Now, did you know that cancer is the leading cause of disease-related and non-accidental death in Australians aged between 15 and 25 years? And in Victoria alone, there are around 400 adolescent and young adults diagnosed each year, and that equates to about 1,500 Aussies. Now, that's a lot. I came across somebody recently and an organisation called Treat Unique Service. Now, it's the first of its type to be provided within the private healthcare setting, and it treats common cancers in the adolescent and young adults space. It was established by an amazing woman, Dr Rachel Conyers. Now, she's a paediatric, adolescent and young adult malignant haematologist oncologist. Can you believe I just got that out? To provide private care for adolescent cancer patients. And she works alongside another superwoman. She's a specialist adolescent and young adult cancer nurse coordinator, and that is Donna Gairns, whose area of specialty, in fact, is haematology and oncology nursing. Guess what? I have them both in the studio with me today. Good afternoon, Dr Rachel and nurse Donna.
Hi, Rae. Rae, how are you?
In unison there. Didn't know who to start with first, but welcome to the show. I'm just thrilled to have you here. And, of course, Donna and I are friends as well and have quite a bit of history. And, you know, over the many years I've watched Donna, you know, in this space where she's truly committed and dedicated to the care of people, especially, you know, our youth and adolescents in the cancer space. So Donna, you do amazing work. But Rachel. Now, Rachel, Donna will know that yesterday when I was speaking to her that I cannot get Sarah out of my head because actually I know a Sarah Conyers.
Do you?
Yes, I do. I do.
Not my sister Sarah.
Oh, right. Okay. Well, could be actually. We'll have to take that offline. Now, Donna, can you just speak up a bit?
Yes.
Oh, that's better. Now, if you speak a little bit further into your microphone, we'll be able to hear you. So, Rachel, you've got quite a rap sheet. Can you tell us a little bit about your trajectory that has led to your founding of Treat Unique?
Yeah, sure. So I guess my my training initially was in kids, in paediatrics, and I really developed my love of adolescents and young adult oncology when I went overseas to the UK in about 2010, doing a fellowship over there. I did it in adolescent and young adult sarcoma. And then from there, really, that sort of, I guess, invigorated me to explore that age group a bit more.
What was it? What was the light bulb moment or that point where you went, yep, this is what I want to do?
I think with some things in life, when you really get something or you might be good at something, it feels a little bit like coming home. And I felt like when I spoke to young people in that 15 to 25 age range, that I was able to make an easy connection with them, and there was a deeper understanding of what a cancer diagnosis might uncover in a young person. That age group is really interesting in many ways. You know, it's when you're kind of creating your own hopes and dreams and becoming autonomous, working out who you want to be in this world. And for me personally, it was just an amazing time of my life. And then when you superimpose on that something like a cancer diagnosis, I really felt for them that it could completely derail everything that they may be capable of becoming or want to become.
And especially at that very formative stage of life. And biologically, you know, we're still pruning back those neurological connectors as well, and that's that exact time. So, as you said, putting an overlay of a cancer diagnosis, which could mean the end of that, it must be extremely difficult for, you know, people who are typically or could be very aimless at that stage and formulating who you're going to end up being, quite disruptive.
Yeah.
What about the families of people that are in this age bracket? Because that's another thing as well, isn't it?
Yeah, so the families, it's an interesting time period because it's not really paediatric in that it's not mums and dads solely looking after those kids anymore. There's that transition where young people start to act for themselves. So it can be tricky sometimes trying to navigate with young people and giving them a voice, but also navigate with parents and giving them a voice.
Because it's hard enough watching parents try and navigate through things like VCE and university and trying to get their kids on track. But, how do you not want to put your child in cotton wool and protect them from this really terrible situation?
Yeah, it's very hard. And I think it changes. It changes as you go through the treatment journey.
Yes.
You sort of have to rethink your approach at different points, and you'll, in equal measures, sometimes have to really support the young person, but sometimes being cognizant that you have to really support the parents too, or the siblings.
And guide them with your experience. Yep. And you talked about paediatrics before, and then we're talking about adolescent and young adult oncology. So how do they define the age brackets? Might ask you that, Donna.
I guess the reason why they're chosen between 15 and 25, a lot of adult hospitals quite often will take patients from 15 in adult hospitals, and paediatrics can take usually up to the age of 18. So that's where this group do fall in the gap, so to speak, where depending on where they're diagnosed and where they're actually referred to, sometimes they may end up in a paediatric hospital, which is sometimes not always the best place for them if they're a mature teenager, and sometimes they may end up in an adult hospital where it's they're surrounded by a lot of old people, so to speak. So they do sort of fall between the gap, and as what Rachel mentioned before, depending on where they are developmentally as well as sort of where they may fit. That 15 to 25 year age group is a lot of rapid change does go through that physically, psychologically, and emotionally and cognitively as well. As you mentioned before, their brains are still developing through that point, and our brains, they think, don't really stop growing and processing and finalising until we're about 25. So they do need a lot of guidance in that area group, and I guess that's where they felt that 15 to 25 is a sort of better cutoff. In some countries, say the United States, they do look at young adults up into the age of 39 too, and sometimes 25 doesn't give them a accurate point of where they're ready to let go from their parental
constraints.
Yeah.
What about children who may have behavioural issues or disruptive issues like autism, Asperger's, who are behaving differently? You might get somebody in that 15 to 25 age bracket, but maybe behaving more down the other end of the scale. So how do you define where that person might prosper better, I guess?
I guess that would be with the service, and what we do is actually do a very comprehensive what we call an adolescent young adult screening system, where we would have an interview generally with the family, and also with hope to get the young person alone as well, and so get a gauge of where they might be developmentally by giving them the opportunity to have that one-on-one time, so we can then explore where they may be emotionally and maturity-wise as well.
Yeah.
Looking at their whole family. Sometimes a young person, if they're the oldest, for instance, they may not, sometimes category might not be as mature as, say, if they're the youngest of four, for instance, they may have grown up it. So we've really taken a lot of factors to where the young person may be and what would fit them.
And I know we're going to speak later more about Treat Unique and the breadth and the depth of services that you offer that cover off when you're talking about assessment and different kinds of support that pick up all of the key features of what it might feel like later in the show. But why is cancer in this population different to other ages? I know we've talked a little bit about the changed profile, but...
So I guess, so the teaching around adolescent young adult oncology most recently has been that there's been no increase in survival over the last 25 years in survival outcomes. And that's pretty much in stark contrast to the gains that have been made in the paediatric and also in the adult sector.
Yeah, because I heard a statistic not long ago, like 90-something% survival rate.
Yeah,
in general cancers.
Yeah, so it's and it's not in all subtypes of cancers in adolescent and young adults, but there is a kind of a clutch of 5 cancers which still have really poor prognoses, and that kind of, I guess, was the catalyst for why adolescent young adult oncology started to get a voice back in 2006, and there's quite a lot of money put in by the Commonwealth Government. Together.
Has that been wisely spent, do you think?
Yes.
We ask all the tough questions on this show, Rachel.
So it definitely raised the profile of AYA oncology and got that statistic about survival out there. And then I guess since then there's been an exploration of why the survival stats are not adding up, and partly that's because of lack of research into this age group, because they literally are spattered all over the spectrum of cancer care. They're not centralised. But also there's probably something truly different about the biology of their tumours, being higher risk than paediatrics, as an example. And then
is there a reason for that, though? Is that the developmental thing that we've been talking about, or...?
It's probably just the mistakes that their cells develop that mean that the cell can't switch off and die and becomes a growth or a tumour cell. Those mistakes are harder to switch off. We are not yet at the point of knowing why that might be more prominent in an older adolescent than a 3-year-old, for example. And I guess the other reason that perhaps adolescent young adult oncology survivorship wasn't as good is that they, up until now, haven't really been entered on clinical trials and studied as a particular group.
Why is that? Is that because of the focus on paediatrics and, I guess, more of the general population? Yeah,
so in paediatrics, there really is a push for enrolment on trial. So somewhere in the order of 60 to 70% of paediatric patients will be followed very closely, which is a real blessing of paediatric oncology. Adult, I think the stats on adult trial enrolment sat somewhere between 4 and 8%, so very small numbers of patients that are actually being followed really closely. And of course, 15 to 25-year-olds largely fall in the adult treatment centres. So I guess lack of studying them is born out of that fact that there's just not as many trials.
Hence your initiative.
Yeah. So
interestingly though, guys, if you think about paediatrics, do you often get a lot of people that were paediatric patients that then translate into your AYA space?
Yes, definitely. And there's definitely a push of recent years as well to be able to help transition those patients from the paediatric population. And we're starting to get more and more referrals from the paediatric.
But you would think that if they're researching and following and tracking the paediatric space, wouldn't that then follow on into your space?
Yes, definitely. So they are transitioning to our space to be able to care and be able to formulate and continue with those research.
You would have that history.
Yeah. But it's a matter of it being able to capture those patients on that area. And also to add is also the cut-off for some of the trials as well is only up to 18 too. So if we got patients who are, at the paediatric hospitals at the higher end of that age group, or if they're in an adult hospital and they're maybe 15 or 16 years of age, they're not eligible for some of the adult trials that start from 18 years of age as well.
Well, happy birthday and good luck.
Yeah, basically. So they really fall in that gap. There's not too many trials that actually span the whole age group.
Donna, you have a beautiful radio voice, by the way, and so do you, Rach. But just stay with the mic, won't you?
Okay, sorry. I get excited.
If you are having a bit of a bird's eye view here at the studios of 3WBC, which in fact we broadcast out of the beautiful venue of Box Hill Town Hall, we're very, very fortunate. But you would see Donna getting all excited and wriggling around in her chair, and I did tell her not to. But she wants to look at Rachel, to confer to Rachel to make sure she's getting it right, I think.
Which she absolutely is.
Nailed it. We can have fun on this show quite often because of the nature of our guests. Usually is about what does it feel like being you, and we do attack some pretty spiky topics. Sometimes people think we can't laugh, but absolutely laugh away, make some jokes. That's okay. But seriously, going back to what we were talking about, what are some of the survivor gap contributors?
Some of the survivor gap contributors is, as we mentioned before, it's a very important time in life where there's a lot of transition in their lives. So young person gaining independence, their autonomy, learning out their sexual identity, who they are, their own identity. And also it's a time where they're looking at their careers in the future and what they're going to be doing, and schooling and all that sort of thing, as well as relationships and starting families. And cancer diagnosis can really interfere with a lot of those big milestones that a lot of young people are naturally going through.
Especially purpose, which is the main driver of the human condition.
Exactly. And if not properly supported, they can really be misdirected, and so needing a lot of support. Also in the physical domain, a lot of these treatments can actually affect them health-wise for the future. So
fertility, for one.
Fertility is one. So starting families, it can also interfere with some of their development and how they build relationships as well. So not being able to going forward for families and relationships.
Because when you're moving through this space, is it like being in a bit of a bubble, where all of a sudden you're in this environment and the rest of the world might kind of disappear a bit?
Can be. I think that's how some young people cope with it. I guess in providing support, we're trying to prevent that from happening. We're trying to, get that normal trajectory of life still happening alongside of the cancer treatment and experience, but it's not always easy, and I guess it depends on the young person's coping mechanisms and also their family's coping mechanisms.
Yeah.
It can be quite, at different time points, it can be quite different for different patients too. So you often you'll find like the adrenaline at the start, when you first get a diagnosis, everybody just wants to get through to the end of treatment. And often young people and their families are very good at doing that, but the wheels start to fall off and that bubble, I guess, starts to disintegrate once you finish therapy.
Yes.
And that's when we see a lot of mental health issues or risk-taking behaviour start to kind of
emerge,
bubble to the surface. Yeah.
I was speaking to a friend of mine over the weekend who works with the Royal Children's up in New South Wales, and she works as a she's not a physical therapist, but she works in that area where they're developing programs around getting the children out of the hospital into activities that are, I'm saying this in air quotes, normal activity, normal physical activity, which is getting some really good traction around the good outcomes and around keeping people and children and families better supported in that normal space to avoid falling into that environmental piece that's very difficult to bust out of once you're moving forward.
Yeah, and I guess these are some of the issues we try to encapsulate right at the start of their treatment as well. So seeing where some of the risks might be and be able to formulate that support for the young person so we can carry them through their treatment and hopefully minimise the effect by the end and through to survivorship. So it starts from diagnosis.
Yeah. Now, we asked Rachel about her entree into this space and what really lit her fire. What about you, Donna?
I started with haematology nursing over 20 years ago now, and I did care for quite a few young people, being haematology, oncology area, and I guess again I just formulated a bit more of a bond and an understanding that these young people did need that little bit of extra support, and recognising early on that they do have special needs compared to some of the older population by even the way I nursed a young person. But again, you're taking the whole family in and their friends and helping them get through to the other side as well. So I found my calling again as well, and kept that interest as well throughout my career. And when I joined the Victorian Cancer Service, adolescent cancer service, it was almost a really good formula base for this role as well, by caring for young people and how we can help survive their survivorship outcomes and moving forward from there. So, and do some extra studies on the side as well.
I know that because you don't have enough to do.
Exactly. So that really confounded my interest in specialising in this area. So. Yeah.
Well, we're going to go to a break in a moment, but before we do, I want to ask you both. We're talking about people here and we're talking about individuals and families, and Donna, you also mentioned friends, which is very typical of people in this age bracket to have big communities of friends. Number one, how do you manage the expectations of everybody in this space with humility and providing dignity and preservation of pride and look after yourself at the same time? I'll ask you first, Rach.
Oh, it's a tricky question. So I think providing, a humility and hearing the young person's voice is, you become better at that with time. And I guess you just need to keep that at the forefront of your mind, whilst also taking into account whoever their best support network may be. And as you alluded to, it can be very different to what we would see as traditional family, I guess. In terms of looking after ourselves...
You hesitate.
It's actually, you get asked this question a lot doing oncology care, and I think part of it is about knowing yourself, and sometimes the patient interaction actually helps you to know yourself better over time, because you're confronted with some pretty hefty issues and sort of makes you face some of your own fears sometimes. So knowing yourself and then creating space for yourself to de-stress, process difficult interactions, think about how you might have done things better, because you can always do things better, I think. So a bit of reflection time. For me, that's about having time with my family and my little one at home, my husband, friends. And I guess sometimes it's about spending time with just yourself too, making sure you've got some alone time.
Thank you. What about you, Donna?
Yeah, again, with caring for a young person, again, it's just looking at what's most important for that young person. It can be completely different, like very family orientated, but then again, it could be a young person as well left home. They might be alienated from their families as well, and sometimes the friends are their caregivers too. So really respecting, not being judgmental of a young person and looking at what their choices are and what they feel most comfortable. But you also get the issues with sometimes families on the side who want to help and sometimes
forcefully help.
Yes, exactly. So but you're also having to respect their anxieties and their needs too, but not compromising the young person's confidentiality and what their wishes are too. So it can be quite tricky on that side of things.
Because it's just not about nursing, or it's not just about helping a person medically through the space. It's how do you navigate? Because sometimes, I don't say side effects anymore, I call it effects. And that's thanks to my friend Jill who taught me about that. But we talk a lot about side effects of something, but it really is just an effect, and how that really just impacts everybody. But you're one person sitting in a whole community of people, and it's often overlooked because you're experts that you're bulletproof and that you're okay. And I know you, Donna, I don't think I've ever seen you with an upside down smile ever. And the way that you carry yourself is always so positive and caring, and I love being your friend because it always feels good. And I don't know you, Rach, but you seem pretty cool and really nice.
Right back at you, Rae, that's for sure.
Rachel Conyers and Donna Gairns, and they're here from Treat Unique. And Rachel, I'm going to get you to describe who Treat Unique are.
Sure. So Treat Unique is the name of our adolescent young adult haematology and oncology service that we recently opened.
When was that? It was last year, wasn't it?
June last year at Epworth in Richmond. And it's the first private adolescent young adult oncology service in Victoria. Actually, we think in Australia.
You think? So you've not sort of seen who your competition is?
We don't want to be definitive about these things. So we started it last year, and it's in essence it's a boutique service for 15 to 25-year-olds with malignant haematology or oncology conditions, or who were treated as a young person and need follow-up of their various health issues after having a cancer diagnosis. And it's it is a unique approach in that it's a multidisciplinary team of health professionals and who are all really there to support the young person in an individual way to make sure that their cancer diagnosis is, I guess, the least disruptive it can be and the most well-supported service it can be during the 4 to 6 months that it takes to treatment, and then well beyond that in what we call the survivorship period, which I actually hate that term.
Yeah.
It's an awful term.
Is there an alternative?
Oh, there's not a good one that I've thought of. Essentially, survivorship just means once the treatment has finished, following up all of the aftermath of issues that can arise having been treated or having had that diagnosis, a lot of which is mental health, actually.
Yes, our mental health and well-being, as you know, I work in this space and we're still trying to knock down those stereotypes that physical and mental health sit apart, whereas they do have direct impact on each other. So if we're looking at integrated well-being, we're getting a little closer to being able to, I guess, respond to the human condition in its individual form. So I guess, that's what we're talking about here today is you guys have created this organisation or this setting where you're addressing a particular condition in an age group, but then pulling apart that individual response and reaction to what it might feel like being and I don't even like using the words patients either.
Yeah, I know.
It's, it is that, but is there
a bit clinical.
An alternative? A client? Sometimes. But how do you see, in terms of when you say take on somebody into your organisation for support and care, that what are some of the mental health outcomes that you see that are typical? If that makes sense.
We can both probably answer that question. Maybe, shall I start?
You start, yeah.
Fight it out amongst yourself, ladies.
So I guess anxiety and depression and risk-taking behaviour are probably the three that pop up in that age group generally. And then if you have a stressor, whether that's VCE or parents separating or, God forbid, a cancer diagnosis, they can pop up earlier or, I guess, in more of a magnified way than they would.
How do you distinguish if it's related to, having a cancer diagnosis, given that you know, we talk a lot, and we've got a lot of literature around anxiety and depression and self-harming suicidality that affects everybody. So is that typical of the age group, or is it, you know, connected to the situational crisis?
So there's been lots of work. Actually, the psychosocial space has had a lot of research within it, and it's found that compared to the base level of adolescent anxiety and depression, it's actually quite elevated again. So, you know, 2 to 3-fold higher an incidence than what we would see for any young person going through that age group. So, and I guess from that we presume that that relates to having a life-threatening illness and all that goes with getting rid of that, or in some rare cases not getting rid of it.
Yes. What does that look like from your perspective, Donna?
On addition to what Rachel mentioned, I guess it's it could be some preconditioning there already. So hence you're doing quite a good evaluation of that and good history with the patient, and maybe even speaking to their family as well, and seeing where their risk factors could be, if they've got a history of any anxiety or depression, and obviously care for that throughout their treatment as well. But sometimes if they may not be coping with the treatment side of things, they can come up through their treatment and being able to.
It's interesting, like how do you triage that? How do you go, this comorbid, suicidality that comes with, cancer? Like which one do you treat first? Which is the most urgent? I guess both are, but what becomes the life-threatening situation?
Yeah, and sometimes they can. Sometimes one can really hinder the other. If you end up with a major mood disorder or really bad anxiety, that can be equally disabling. It can affect the ability to make, I guess, rational decisions which need to be made at certain time points. And in its rawest form, I guess it can be young people walking away from treatment.
Wow.
Because they've just had enough.
Yes.
And that, I guess that for us doesn't mean that we've failed, but we really shouldn't be getting to that point. We should be able to try and support them enough to work through the anxiety or the sadness or
And
the
would that be
stress.
for a range of issues that somebody might walk away, it's too painful, or there's not enough support, or it's just, people self-sabotaging to go, well, I give up?
Yep, all of the above,
Okay.
I would say.
And also where they live, comparison to their treatment as well. That they might want to travel down. They'd rather be at school or staying closer to home, or thinking other things are more important because they might not understand completely. So making sure that they have all the information they need in a language that they understand as well, and be able to give them time to process sometimes.
Yes.
So sometimes we might need to have that general discussion, but we have to repeat that discussion again so they completely understand the consequences. As we mentioned before, they're still trying to develop their processing skills and their problem solving and their coping skills as well. So depending on the individual situation is how we
And given that you guys
them.
are so prominent on their survival chain, does that then have an impact where, say, families might come and pour all of their grief and frustration onto you, like, you failed? Why haven't you fixed my child?
Sometimes, and it can be quite challenging.
It would be quite distressing, I imagine.
Yeah, no, definitely. But we also ensure quite often that they have their own individual space to be able to talk about their fears and their challenges as well, and sometimes quite often separate from the young person too, so they've both got they feel like they can actually talk and express how they're actually feeling without the other around too sometimes.
For both of you, and I'll ask you first, Rach, has there ever been a situation where you've connected with a patient that you've been unable to even resolve your own feelings, or it's really affected you in a way that has impacted your own personal life?
I think honestly every human that was working with young people in this situation would have a time when you either, not that you get too close, but it
slips under the radar.
It slips under the radar, and sometimes it's hard to know which patients they will be, and sometimes it's the patients that you didn't expect, and often you realise that it can affect you personally or, you know, other parts of your personal life at really critical time points. So, you know, when you're giving bad news, when disease is not responding to chemotherapy as an example and you need to palliate, then that can be a bit of an unravelling point as a clinician.
And for those of who are unfamiliar with what palliate means, it's, you know, to help a person die
peacefully. So yeah, there's definitely been various patients and families that you realise you've got that real connection with, and it hurts. It hurts when it doesn't go well.
Yes. I'll just take a bit of a deep breath. What about you, Donna?
Yeah, most definitely. In addition to what Rachel mentioned, it's also, you know, in yourself ensuring that you have covered all the bases and you've spent the time and the effort to make sure that they're well catered for, and then if they've decided, for instance, that they don't want to go ahead with any further treatment, ensuring that they do have the supports around them too.
Yes.
And so they've got someone to fall back on, or, you know, being available to them where they can too. So it can be quite challenging.
But the code of ethics, you know, in any caring profession is that you don't get too close, and that, you know, even in my space as a counsellor, don't touch, don't, be personal with people. But I think it's important, and sometimes like, I don't care about the code of ethics, come and put me in jail. I'll give you a hug anytime.
Yeah, sometimes as a nurse and the doctors, a health professional, you do put sort of what's the word I'm trying to say?
Compartmentalise.
Yes. And so, but it still can affect you into your private life too.
Yes.
But how you adjust with that.
But also part of the process, and if we talk about the grieving process that Rachel just described, of being close where you're, you're all deciding that this person probably can't be helped or intervened any further, that are you allowed to go through that grieving process yourself, publicly, or do you have to, keep that information from families? I'm not sure if that helps with everybody's process of letting go to be, you're so high touch. Is it important that you are part of the grieving process for people, and vice versa?
Yeah, for me, I think I've changed in my view of that over the years. I think when I was a young, naive doctor, I was much better at compartmentalising and kind of, I guess, being the information giver.
Was that before you had a child as well?
Oh, having a child has definitely wound up the intensity of all that. But even before I had my son, I think you realise that people want you to be a person, and some of the best interactions are actually the really honest ones where you give of yourself, and sometimes that means getting emotional with patients, which maybe somebody outside of that sphere might see as being unprofessional, but somebody that lives and works and breathes in that sphere would see as just being human. And I think what I've learnt with experience is that actually families do, and young people do, really appreciate that honesty, and it's kind of being real,
because the human condition does respond very, very well to transparency and care. The feeling of being cared for is so much more powerful than being told that you're cared for. We care, but we won't touch or get involved in your space because that's private. But really, it's not even private for you as well, because you're seeing really quite deep into people's lives.
Yeah. You're with them along this journey for many months as well, and sometimes years. And you do get to know each other's lives. They get know a little bit about my life, and I know a lot about their life as well. So it is hard to turn off sometimes.
Especially for nurses too. I reckon nurses have such a much more intimate involvement at the bedside, but also after the bedside with the patient. The nurses are angels.
I think, if anyone in the federal government is listening who has healthcare funding, give some more to nurses, because I want Donna to... No. No, I just think you're right, Rach, so underrated in the work that nurses do, and also what level of care happens after that. And I know, Donna, you and I have had a few conversations over the years of when you leave work, it's like you jump out of a lift, you know, the bottomless lift, like there's no support or no help when you've had that entire day of managing people's lives in a very intimate way. It's, you know, I mess around in people's heads, but I don't do the whole thing. It must be terribly draining sometimes, and if you don't have that support network, there's always a bottle of wine, I guess.
Yeah, that's true. But I'm very lucky. I've got that family and friend network and being able to debrief when I need to as well. I'm pretty lucky there. So you need to be able to do that.
Now, can you believe we're getting to the end of the show? You said at the start, I'm terribly nervous. How are we going to get through this hour? And we did. But I really want to be able to help listeners understand, in terms of Treat Unique, if they feel that they can refer or want to know more about what you guys do, how do they get in touch, and what might you expect, and what are the types of people who should contact you?
Sure. So I guess the one thing I haven't mentioned is the other members of our team who I guess provide the full picture of the service. So there's obviously a couple of medical oncologists, Donna, our nurse coordinator, and then we have a wonderful social worker, Christina Leonardis, who has done a lot of work in the cancer space for adolescents and young adults, but a lot of work with adolescents and young adults outside of that, with trauma and mental health issues. So she is another person that works very closely with the young person around mental health, keeping the wheels turning over in life. We have a ex-ballerina exercise guru who's a Pilates instructor, Rachel Fraser, who is there to, I guess, marry exercise with a cancer diagnosis and help with some of those body image issues that come up when you are getting lots of therapy and feeling, and this is for males and females, feeling like your body isn't yours. So she does a lot of excellent work there. And then our final member of our team is another Jackie. So we have two Jackies, two Rachels. And Jackie is actually an ex-patient of mine from over a decade ago who herself had a very high-risk tumour as an adolescent. She was 16 at the time and has gone on to flourish really as a young person. She's now a trainee doctor, and her role is really born out of her own desire to help young people who are going through this. So she's we've called her officially a patient advocate and a mentor. And she is there to answer, I guess, all the questions that our patients feel like they can't ask us, or that are more aligned with being a patient.
Nothing like a lived experience.
Totally. So she provides that. So that's the whole team.
Well, that's so small when you think about what you guys deliver and get across.
I know. And all women too. Not that we're feminists, but you need to think about
I like that you also talked about, you know, body image issues, and it's something that I've got a regular couple of people that come on this show that talk about men's body issues and disorders, and we don't give that enough airtime to recognise that, you know, this affects everybody.
Totally.
But that's fantastic that you're addressing the entire condition, not just trying to solve the problem, which often I think in medical intervention is the primary purpose.
Totally. And it all gets forgotten. The rest gets forgotten about. So in terms of getting on to us, you can go to our website. So our website is www.treatunique.com.au.
That's pretty easy.
Pretty easy, all one word. And then, or you can call our reception staff. It's 9516 2666. And off the website you can write us an email, contact Donna or myself directly. And really we're set up for new diagnoses, but also set up for, here's that word again, survivorship care. So if you've been treated as a young person and you want to make sure that you're following up your well-being long term, we take referrals from GPs for that as well.
Oh, wow. So you're getting across the broader spectrum of not just, say, problem solving what's in front.
Trying to.
Yes. Now, if anyone just wrote that number down, that is 03 for Melbourne. For those who are listening in from all over the world, as They tend to do. You do take calls from people from overseas?
Yeah, first
Yes.
patient was from Fiji.
Yes.
Of course. Well, you can see an actual photo of this person on LinkedIn. If you look at my LinkedIn post today, there is a lovely photo of Rachel and Donna with your patient, with John and his mum, is it?
His mum,
His
yeah.
mum from Fiji.
Yeah, so that came through the Lymphoma Australia. I work with
Yes.
Lymphoma Australia as well, so that came through that line of inquiry. So, and I probably should mention we're actually based at Epworth, Richmond as well. In
Just
Victoria.
down the road
Yeah.
from here, so falls into our city of Whitehorse and Burundara Pocket.
Yes.
Almost. Now, I always like to remind people that if our show today has brought up feelings that are uncomfortable for people, do call Lifeline. That's 131114. Suicide callback service is 1300 659 467. And of course, emergency services is 000. Thank you guys for coming in today.
Thank you for having us.
Yeah,
A
thank
pleasure.
you, Rae. It's been great.
A pleasure. And hopefully, I know just from listening into, what you guys are speaking about, and we only had an hour, could have gone for ages. Please come back and talk about how it's going. And now you've had the experience of rock and roll radio, you might have some ideas of how we can further educate our communities, our world, around what it might feel like being an adolescent or young person with cancer, and also for their families as well.
Yeah, that'd be wonderful.
Most definitely. Thanks for the opportunity.
It's an absolute pleasure. We're going to get out of here. You have been listening to Rae Bonney, where it really is okay to be not okay. And please remember, by extending just that little bit of kindness and care, you could be saving a life. Take care, everyone.